Um, what? So I know there are a few different devices, and do you take medication in addition to those devices?
In general, yes. So again, let's step backwards a little bit. You know, from the epileptologist perspective, our goal is no seizures and no side effects.
Yeah.
That's where I'm always coming from.
Okay.
Everything from medications to devices to surgeries are just a tool to that end. Okay. So when we look at, you know, how do I get this person seizure free, I also have to balance with, okay, how do I leave this person at least impaired getting that way? You know, I can put you on propofol, you know, forever and ever, you know, stop all your seizures, but you know, you could ask Michael Jackson how that went.
Okay.
That wasn't so hot. Okay.
Yeah.
So I can stop all the seizures. The question is, how can I sort of keep you most awake, keep you most thinking, preserve as much memory as possible, not create any neuropsychiatric problems. Okay. So in general, I would say we know that the medications aren't working efficiently. After you fail one or two drugs, the likelihood that any additional drug makes you seizure free is, you know, approaching 1% or less.
Okay.
That said, if we sort of intervene with a device or a brain surgery, the first goal would be, you know, in the first several months to a year or two, make you seizure free. And you know, if we get there, then we're super happy. In all likelihood, you will still be on medications at that point. After you cross that sort of 2-year threshold, we feel like, okay, the brain hasn't had a seizure in a long time. It probably maybe has unlearned how to seize as badly as it used to. Do we still need as many drugs? And that's when we start to slowly peel them back.
Okay.
And I'm talking about over the course of half a year to a year. You know, not like, okay, it's not tomorrow. Okay,
Yeah.
that's a bad idea.
Okay.
Yeah. Which is what happened here, right? You stopped you immediately and boom, boom, boom.
Yeah,
You popped off
yeah.
a bunch of seizures.
And that's kind of what happened when I started having seizures. As soon as I was having multiple a day, and then as soon as I started medication, then I started having some amount per month instead of every day.
Instead of every
Yeah.
day, that's right.
So it lessened them, but it did not make them go away by any means.
Yeah. Remind me again your seizure.
What do you mean?
Do you get a warning at all?
I get like a zap.
Yeah. Talk to me about that zap.
Didn't you say you have an aura first?
I get a zap first. And
Oh,
then
zap.
And then I get sometimes an aura. Sometimes it started with auras, but now I just get like a zap, and then I get like a deja vu kind of.
Is the deja vu your aura, or is that separate?
It used to be separate, and now
It's the same.
it's kind of all one.
But something happens before the deja vu, and that zap feeling. Can you describe where it is, what it feels like? Pretend I'm like your 10-year-old nephew.
Yeah.
Use super simple words.
Sometimes it feels like there's just like an electrical bzz that comes in my head. I'm not sure exactly where in my head. Sometimes it feels like it comes up from my chest, but I'm not quite sure. It's different most times.
Is it more often the chest or more often the head?
I'd say more often the head, probably.
Okay, it's inside the head.
Yeah.
Is it on one side of the head or the other?
I don't know.
Okay.
I
But it's
just feel
super
it.
fast. It feels like an electrical buzz.
Yep.
And when it comes from your chest, where is that? What do you mean?
It feels like it comes up.
It sort of rises.
Yeah, rises.
Okay.
And I'd say probably 25% of the time it comes from that.
So head is 3 to 1 chest. Okay.
And then I go into like
And
a deja vu kind of where I know I'm not in that place, but I think about, oftentimes I think sometimes, well, not every seizure is the same, but sometimes I think about places from my childhood that pop into my mind. And there are certain places every time, like my grandparents' house, a resort that we used to go to when I was a child, a friend's house that I spent a lot of time at as a child.
there's always a place.
It's always a place, yeah. And then sometimes it's just like I'm in a meeting and I feel like I've had this exact conversation before, or I've been in this exact situation before, even though in my mind at the time I know I'm having a seizure and that's not the case.
Super interesting. And how long does this sort of familiar experience of being in a place or being in a situation, how long does that last?
Feels to me like it lasts about 20 to 30 seconds, but I'm not always exactly sure.
How many times did that happen for you while you were here this week?
3, those times.
So you felt it each time.
Mhm.
Okay. And if this is allowed to go and you didn't have meds on, what would happen next? If you had the deja vu feeling,
And I didn't have meds.
yeah, what would happen next?
I would probably still come out of it.
Mhm.
I might have facial twitching with it. That's how it started before I was on meds.
Okay. So facial twitching is the very next thing?
Yeah,
What side of your face?
I think usually my right, because I always like kind of cover my right side
Uh-huh.
with my hand.
Mhm.
And I would just have a lot more per day, like I said. Yeah.
Good. Okay. And I can't remember, I haven't reviewed it this week, but have you had abnormal imaging? Have you had an MRI with anything for any of it?
I had an MRI that showed nothing, I don't think, and I had an EEG in the ER.
Okay.
That did show epilepsy. That was with St. Mary's in Grand Junction.
Gotcha. Oh, which reminds me, Dr. K mentioned that you wanted to transition care
Yes, is that
to
okay?
here in Denver?
Can you see me remotely?
I can.
Can you see me at all?
Yes. Oh, no,
Okay.
absolutely. Yeah. No, yeah, absolutely.
Okay,
Yeah. Okay. Would you like me to have a conversation with Dr. Collier?
yes,
Okay.
please.
So does that? I'm sorry. Do you want to see both of us together?
No, I'd rather just see you if I
Okay.
could.
Okay.
Yeah,
Yeah. It is convenient to have somebody close by,
okay.
who's aware. You know, and she's an epileptologist as well. She just doesn't have the tools that we do here, and doesn't have access to the surgeon that we do here. Obviously, a tremendous advantage being in a bigger city.
Yeah,
But it is, if you're rolling up on Friday, you look down, oh my goodness, I'm about to run out of meds. It's nice to have somebody close by.
so that she,
Yeah,
to
okay.
prescribe it.
Yeah, is that okay? Do you have a specific issue with her?
No, and as far as like prescribing and stuff,
Mhm.
if she's there for that, that's fine. Or
Okay.
I'd rather just not see her. She gets kind of irritated when I forget things, which I feel like is part of.
Really?
Yeah.
Well, I don't understand.
I take my sister with me to appointments.
Yeah, no, this
And
is.
yeah, she just kind of like, you don't remember. I'm like,
Oh.
yeah. So
I went with you twice, and she
Yeah.
seemed kind of indifferent,
Okay.
not as engaging as you are, let's say.
yeah.
Plus, I think there's more trust with you already than with
I've
her.
only seen you twice.
I know. I've been seeing her for a couple of years.
But I think it makes sense to have her in the loop.
I think it does.
But I think you can
Yeah.
negotiate that more
Yeah.
fairly than she can.
And to be honest with you, if we can't have these sort of conversations about surgery, etc., ultimately she would hand you over to our program anyway. Okay, but it still makes sense to have somebody sort of close to home who's aware of things, who can sort of help manage and knows you. Say, for
Yeah.
instance, you end up in the emergency room, nobody knows you,
Yeah,
and
that
they,
makes sense.
their first
Yeah.
call is going to be, neurologist
Yeah.
in town, and she's
Yeah.
going to go, oh, I know this person.
That makes
And
sense.
she would probably-
think, oh, I'm going to call Swedish in Denver. No one's going to do that.
Right.
Yeah,
Okay.
and she would communicate with you if
Yes.
necessary, because
Yeah.
you're the doctor of record
Yeah.
mainly.
Yeah.
Yeah,
Okay.
okay.
Sure.
And you are in her network, she checked.
Oh, that's
Yeah.
great. Excellent. Okay, thank God.
Yeah.
We're trying to figure out how to do all this insurance stuff, which they don't teach you in medical school.
Oh, yeah, of course.
Yeah,
Yeah,
exactly.
and you're in a new clinic or you're in?
Yes.
Yeah.
Yeah, so
okay.
I left the academic world in September.
Mhm.
Started with a private practice near the Porter Hospital, which is part of the Centura system.
Okay.
But I've always wanted to be involved with this epilepsy unit here. So it's weird because my private practice is has a relationship with Centura, but this is a health one.
Mhm.
And yeah, and all this kind of weird insurance-y stuff
Yeah.
that they'll teach you about.
Well, she didn't look. The insurance person didn't look up your clinic, but she did look up your name.
Yes.
And so,
Yeah.
and she said you're in. So
That's
that's
fantastic.
good.
Okay. Yeah, shouldn't be a problem.
And then Dr. K said that you guys were unable to see my facial twitching on the EEG. That first.
Yes, so I mean, the resolution
Mhm.
is really good,
Mhm.
actually much better than the lab I used to work at, but still, I think it was a nurse who said, oh, the patient's face is twitching, which I still couldn't see even after I zoomed in,
Yeah.
but that's okay.
Okay.
It all fit, your description completely fits, and I'm so glad the nurse was able to sort of see it.
So the nurse
The
did.
nurse saw it.
That was my next
Yeah.
question. If they were able to see it, or if it's all in my
Yeah,
mind.
I think it's just the third one. The third one, she was standing on this side, and she calls up to the camera, patient's face, the right face is twitching.
Okay.
Yeah.
Well, that makes me feel better. That's
Yeah.
not. In
You
my
know,
head.
you're not crazy.
I mean, it is in my head, but it's not in my head.
Yeah.
Well.
So
Can
is
you-
that part of? Is that an epileptic thing also, or Dr. K said it could be?
You know, it's all part of the same thing. Think about
Okay.
your brain as a dry grassy field. And that spark falls on
Mhm.
the grass, and a little tiny flame starts. That's your sort of zap. As that fire starts to spread and engulf the grass around it, that's when you sort of evolve into that deja vu feeling. And you didn't have a big convulsion here, but that's what happens when the entire field catches fire.
Mm-hmm.
But even past the deja vu, gets a little bit bigger, that's when the right face starts to twitch.
Mm-hmm.
And then your brain sort of extinguished the fire by itself.
Okay.
Okay? If you were not on meds and didn't have some in you,
Mm-hmm.
then that would be.
It probably would have blossomed
It
into.
probably would have blossomed into
Yeah.
a thing. So you understand? So that's why it can
Yeah.
look at very different, even though it started in the same place.
It's because I have meds in me.
Yeah.
Probably. Okay.
Could you explain what some of the, you said there are some devices and then there's some surgery. Could you kind of tell a little bit about
sure.
that?
So let's go backwards a little bit. What have you talked about with Dr. Collier? What's your understanding of what our capabilities are in 2022?
She said, I want you to go get an evaluation at the hospital before I prescribe any more medications to you.
Okay. Was she concerned that you weren't having actual epilepsy?
Well, she saw it on the EEG, so
Yeah.
she knew I had epilepsy.
Okay,
She
good.
saw that the medications weren't really working.
Okay.
And so she said I'm medicine resistant or something.
Yeah.
But she didn't know what else to do, I guess, at that point.
Okay.
So she wanted me to come here.
Okay.
And
Did she talk to you about VNS,
she
GBS, RNS?
she said they'll figure out where in the brain it's coming from and then decide which device might suit you better. And she gave me 3 names,
Yeah.
but I don't know what any of them are
Yeah.
really.
Okay. I'll tell you what. Let me. I'll keep that information since that's useful information. Okay. So let's see. This is your brain. Okay, we're looking at you. These are hippocampi. These are your primary memory structures. Okay, this is the right side, and this is the left side. Okay, so you're looking out at us.
Okay.
Okay, and you can have this.
Okay.
So your MRI by report is negative. Okay, so there's no scar, there's no little extra piece of tissue that's causing us problems.
Mm-hmm.
The epilepsy monitoring unit stay suggests that your seizures are coming from the left temporal lobe.
Okay.
Okay, and so the rest of the workup includes something called neuropsych testing, which I'll explain, and probably for you something called a WADA test. Okay, but neuropsych is like a 6-hour IQ test, right?
I did that, and
You
I
did.
provided you with those.
Yes. Do we actually have the report, or we had
Yeah,
the
I
location
gave the
of it?
report. I gave the nurse printed the report,
Uh-huh.
and I gave it to Dr. K. And
Okay, good.
what did it say? Avery, what was the name
Oh
of?
yes, actually I remember we talked about it.
What was the name of the
briefly.
disorder it said I had? Adjustment.
disorder? Okay, but it
That's all it said.
was the neuropsych test done for purposes of memory,
Memory.
and function.
Memory. I
Okay,
think.
so memory's good. Okay, good. Did it show any sort of weakness at all? Yeah.
I was in the 25th percentile for some things.
Oh, do you remember what?
I don't know. I don't know if it was memory related or
It's-
spatial related
It's
or.
a trick question, right?
Yeah.
If you didn't have,
I don't
if you didn't have a memory
remember.
problem, then you would have.
I read some of it
abnormality.
to my mom, so I was
Okay.
hoping
She
she.
certainly has memory issues now.
Yeah.
But they're
Yeah,
not.
but
They're
no.
not really related to. They're related to episodes in my life. They're related to
Yes, that's right. We talked about that.
events.
yesterday.
So it's hard. I don't know how to test for that.
Except that's very interesting. When you have your deja vu, it's also events and place related.
Yeah, but that are. It's like my memory is washed out
Mhm.
practically from a certain age on until now.
Okay.
Before that is fine.
Yeah.
Yeah.
Okay. So that's the third thing. So all three are done. Now the WADA test is a interesting a procedure, and it's invasive, and so we think very carefully about when and how to use this. But
Mhm.
I'll describe to you the procedure
Okay.
and tell you why it's important in your particular evaluation. But it's an interventional radiology procedure. So if you've ever heard of anybody, a friend or family member who had a cardiac stent,
Yeah, my dad had.
yep.
has
What they
that.
do is they put a catheter into the leg
Mhm.
and they snake it into your heart and then drop the stent in the vessel that's plugged.
Yeah.
In this procedure, we pass the heart and we go into the carotid artery. We don't enter the brain, but we leave the tip of the catheter in the carotid artery and we infuse a medication that can temporarily stop the function on one half of the brain. So it
Oh.
looks like the person's having a stroke on the tape.
Oh.
The reason we do that is we want to sort of knock out one of the memory structures at a time and leave the other one functional.
Mhm.
The medication we use has about a 5 to 10 minute life, and then it wears off and you're perfectly back to normal again. But in that time, what we do is we give you flashcards,
Mhm.
and we make sure you can see them and hear them. And then after the medication wears off 10 minutes later, we ask you what you remember. And by doing that, we can sort of develop a score. Is the left side healthy? Is the right side healthy? Is one side not healthy? Are both healthy? Or both not healthy? These are all things that we want to know. In the typical scenario, in the classical epilepsy surgery workup that developed in the mid-1950s, we would want to see an abnormality on the MRI, something called mesial temporal sclerosis. In your situation, we would want it to be on the left side. We would want to see that the seizures are coming from the left side. We would want to see that the neuropsych test says everything but the left side is normal. And then in the WADA test, the memory test, we would want to see that your memory is preserved on the opposite side.
Mhm.
And if all four of those things line up, what that tells us is that this area is scarred, causing seizures, and not helping you remember anything, so you don't
Mhm.
need it.
Oh.
And we would go in and remove it.
Oh.
And there would be a 4 in 5 chance of curing your epilepsy.
Mhm.
Okay?
Okay.
That's the ideal scenario.
But since I don't have some of those.
It's less ideal.
Yeah. Uh-huh.
Okay. Something that we still sort of think about and might pursue, but that's when the neuromodulation, the devices, become a really good sort of intermediate first step.
Mhm.
Okay. Because you don't have a lesion. Okay, so if you did have a lesion, like I said before, you'd have about an 80% chance of becoming seizure-free after surgery. Without a lesion, that number drops to 50%, which is still pretty good. You know, when you think that with medications, you only have about a 1% chance
Yeah.
of becoming seizure-free.
Mhm.
Okay, but because it drops so much, we start to think about doing a more narrow surgery. We can do a laser where we just fry that thing, or we can think of one of 3 devices. The first one that came on the market is something called VNS, and that's the vagus nerve. And we have vagus nerves that we can access in the neck, and the vagus nerve in that situation is exposed,
Mhm.
put a coil on it, and connected to a generator that's implanted under the chest, kind of like a pacemaker.
Mhm.
Okay, and the VNS is really interesting. It has 3 main functions. One is like a medication where I slowly titrate it and we kind of find how you do, do you do well, do you not do well? If you have side effects, you don't have side effects, just like a drug. The second function is like having a paramedic standing by. If you feel your aura coming, you feel that zap, you actually carry a magnet with you, or people around you can carry a magnet. You can swipe the generator and trigger a stimulation to try to stop the seizure from progressing.
Oh.
And the third and newest function is kind of like having somebody watching you while you're asleep. Sounds creepy, but it's actually really helpful, because with about 80% of seizures, there is an acceleration of your heart rate that this thing can detect. And so even when you're sleeping, even if you're like unable to sort of trigger the device, it can trigger itself.
Okay.
So it's pretty cool. Okay. The next device, actually the next device in development, not in approval, something called the deep brain stimulation. And this comes out of our Parkinson's sort of surgery options. And so this is a lot more invasive. So the vagus nerve is exposed in the neck. We never enter the skull. Okay. The deep brain stimulation puts two probes directly into a structure called the thalamus, and then that's connected to a generator too. And that intermittently stimulates the thalamus, which is a central part of the seizure network. And we think that by constantly stimulating it, it slows seizure progression too. The two together have about 10 to 15% chance of becoming seizure-free.
Okay.
Okay, so meds, 1%. VNS, DBS, about, I say 13%, kind of split the difference. Okay, this is not as invasive. This is very invasive. Efficacy is roughly the same. So if you hadn't had either, I would probably recommend the VNS over the DBS. But if you fail the VNS, then the DBS becomes an option.
Okay.
Does that make sense? And the third was actually approved before DBS, but it's more modern technology and it's very cool, is something called NeuroPace, or responsive neurostimulation. Okay, and that's if we can identify where the seizure focus is coming from, especially since you're MRI negative, we would need to prove that the seizures are coming from there by putting an electrode into that structure, and we would want to put one on the other side, probably 3 to be honest with you, on each side along the axis of the hippocampus itself. It kind of goes into the plane of the brain there. And then we would prove which one is coming from, and hopefully just one. Because sometimes we get fooled, because don't forget, on scalp, we're recording out here. Okay.
Yeah.
And so sometimes what happens is it's easier for a seizure to jump to the other side and come out.
Oh, okay.
And it's what we call falsely lateralizing. Okay. So we would want to prove, okay, we think based on the scalp EEG it's coming from here. Let's be really darn sure, because we don't want to make a mistake in you. Okay. But by doing that, we can say, hey, the seizure is definitely coming from here. We know that because we have electrode buried in it. RNS, we can then connect to it a separate electrode and train this device every time it sees that same seizure pattern that we saw during what we call phase 2 monitoring, deliver a small electrical stimulation to stop the seizure. And this way we can actually stop seizures with a much higher efficacy than these guys without removing any brain tissue at all. So it takes no future treatment off the table.
So would that be your first choice?
We would need to do some more homework. We would want to, I need to review the neuropsych test myself.
Yeah.
We would want to get the WADA. Okay. We might, because your MRI is negative, get a PET scan to see if there's an asymmetry as well.
Okay.
And that'll help us make a decision. Once I have all of that information together, I generate a big report, and then I present it in front of a panel of epilepsy specialists like myself, neurosurgeons, neurologists, neuropsychologists, neuroradiologists, and I argue about you. I say, this is what we have, this is what I think we need to do, and people will say, hey, you're crazy, don't ever do that, and we'll sort of argue and establish a consensus so that it's not just me sort of telling you what I want to do.
Okay.
Okay? And then you get to decide. You say, you know what, I think you guys are nuts, I'm not going to do this. I'm going to go smoke marijuana in the middle of the rainforest.
I mean, that sounds great.
So after this consensus conversation, then we can decide. Do you want to move forward with our recommendation? Do you want a second opinion? Do you want to go to the Mayo? Do you want to go to Cleveland Clinic? Okay. Do you want to get as much information as you can possible.
Mm-hmm.
Okay, and then I'll introduce you to our neurosurgeon.
Mm-hmm.
The one we use here is his name is Dr. Meehan. He's
Mhm.
excellent.
Okay.
And Dr. Collier has actually referred other cases to Dr. Meehan.
Okay.
You'd meet him. I know you'll like him, and then you'll just make a decision.
Okay.
And then once that happens, and he and I will get together and we will establish a plan about
Okay.
what to finally do. And then you'll come back in for a repeat test, but this time with electrodes where we think the seizures are coming from,
Okay.
not on the outside.
Okay.
Okay.
My question is, if we follow one of these and it does help the seizures go away, then does the memory ever come back? Or
It's a great question, and it really depends.
okay.
So there are a lot of things that are pulverizing your memory. The seizures are not helping, but the meds probably aren't helping either. And then one of the nice things about the neuropsych test is that they can say, hey, this person's actually really depressed, because depression can do that too.
Mm-hmm.
So when somebody who is not seizing on less medications and less depressed because they're not seizing so much, we often see a good improvement in memory.
Okay.
Can I bring your memory back to, when you were a teenager? Probably not.
Mm-hmm.
No, mine isn't either.
Yeah.
Okay.
Yeah.
As we get older, those things change.
Yeah.
But we can, if it's medically related, clean up as much as possible and see what's there. And so one of the nice things about doing the neuropsych test before the study, before the surgery, is when you have a baseline, we'll probably repeat it again a year later.
Okay,
And
so
you
I
can
would do
see.
another one
Yeah.
with.
And
Okay.
you can see. And then you can say, you can curse me and say, you said my memory's going to get better. And we'll see.
I'm kind of upset about my IQ number.
Yeah,
but-
I can't. Yeah, I can't predict that. In general, they improve or stabilize.
Okay.
What we do know about memory from the early days of epilepsy surgery. This is memory here. Say this is 100%, and this is time. If you do nothing and allow the seizures to continue to get worse, it will get worse.
Mhm.
What was established in probably the late 80s, mid 90s is that the surgery, say time 0 here, if it happens here, with the worst possible scenario is that you take the hit all up front. Okay, with the intention is that the rest of your time is without seizures.
Okay.
Okay, so it's not great.
Yeah.
The memory will change for some people, unless you have a beautifully perfect WADA score, where you have 0 memory on the surgical side, perfect memory on the opposite side, the safe side.
Which is not likely.
It depends.
Okay.
Yeah, we did a WADA yesterday, and it was a very large asymmetry.
Okay.
So will it be perfect? Maybe not, but it'll be like 98%.
Okay.
Okay. Yeah. So I draw this as very dramatic, but that's 100%. For that person the other day, this could be 90 or 98. I don't know. Okay. This is sort of the art of medicine stuff.
Yeah.
We have a lot of experience, but ultimately, each individual person, we can only go by our knowledge and our experience rather than any true predictive ability. Okay.
Okay. Another question is, have you seen a lot of people where they just like later in life just start having seizures? Like me?
Yes.
Yeah.
Yes.
Okay.
Unfortunately, seizures are super common. 1 in 10 people will have a single seizure in their lifetime. 10%.
Wow.
It's very high. It's 1% or a little more than 1% that have recurring seizures, and that's what we call epilepsy. And so it's actually it's bimodal. Okay. So seizure frequency. Again, this is time, and this is seizure frequency. I'm sorry, not time, but age. So this is 1, and this is 65. It does this number. So in your 20s and 30s, you're usually the most protected.
Oh.
Around 1, high incidence of epilepsy, and then after we get past 60, it starts to increase again.
Oh.
Okay. The folks that have it here are things that are probably like traumatic brain injury related, substance abuse related, things like that, or clinically silent, neural lesions that we couldn't see and didn't know were there, and maybe the events were always there and we just didn't know to ask. So things like deja vu, people have deja vu. Not everyone with deja vu develops epilepsy.
Yeah.
But, oftentimes when we sort of find somebody in midlife, and they say, oh yeah, I've been having deja vu since I was 7. It's like, okay, well, that's probably what it was. They were there the whole time, just infrequent, and then got worse over time. Does that make sense?
So the very first option device-wise was called the what?
V is in Victor, VNS, vagus nerve stimulator.
And that is not as invasive, and that gives you quite a bit of information.
It doesn't give us information, but allows us to positively impact seizure control.
Oh, okay.
Yeah, so we definitely know we do a good job at reducing seizures. We also give you the confidence in knowing that, hey, when I'm sleeping and no one's in bed, this thing is always listening and can treat a seizure if one happens. That's very reassuring. And then also, especially for you, since you have such a good aura, you can actually try to treat your own. So it's like having a paramedic walking around with you.
Yeah.
So the efficacy improved when you went down device 1, 2, and 3.
No. So actually, it went back up again with 3. So the least effective is medicines at this point. About 1% chance. The VNS and DBS are about 13%. Okay. The RNS seems to get better over time, and we're looking into that 30 to 50% range. And then brain surgery, where we remove brain tissue or destroy brain tissue, that's in that 45 to 50 range, without a lesion. Okay. If we get a PET scan and we say, oh, hey, this area is not working right, that becomes our lesion, and then your chance of seizure freedom starts to go up from there.
So I think it makes sense. It's really wonderfully reassuring that you actually do have a panel.
Yep.
And that you get lots more information, if I understand correctly.
Yes. We're going to need more because we know the MRI is already negative.
And then you will have recommendations about, and then she gets a choice.
What's the difference between an MRI and a PET scan?
So a PET scan is looking at function, and MRI is looking at anatomy.
Oh, okay.
So, and we get at function because what we use for a CAT scan, it technically is a anatomy test, but we give radioactive glucose into your veins, and so glucose is the fuel for all of your cells. And so the theory is that if there's an area that's using more fuel, it lights up brighter. If there's an area that's not using as much fuel because it's sick, it uses less, and so it looks different. So we give you a little injection of that glucose, radioactive glucose, put you in a typical CAT scan, and see where it all goes. And then we can say, oh, this area is blue. That means it's not functioning well. It's slow. Okay, it's unhappy. Okay, that means that may be where the seizures are coming from. If you were, on the flip side, happen to have a seizure during the CAT scan, that area would light up. Okay. Yeah. The image would probably be unusable though if you were convulsing the
Yeah. So, also my question is about triggers or maybe causes, or I don't know what the right word is, but I've thought about hormones, or hormone changes.
Yep. Yes.
I have diabetes, so blood sugar, could that be a trigger?
Yep, blood sugar is definitely a trigger, and that's a trigger for anybody. So when I talk about the 1 in 10 people having a single seizure in their lifetime, oftentimes people who first identify that they have diabetes can present as a seizure because their glucose, the sugar in
Because
the
I
brain is
just
all
was
like that.
diagnosed with diabetes, like, I think 2017 or 18, and then
What kind of diabetes? Do you need
type
insulin?
2.
Type 2.
No, no
Okay.
insulin.
Okay.
I take Trulicity for my
Okay.
A1C, but
Yeah.
and then I started getting seizures, so I thought that's really coincidental, maybe.
Yeah, no, it's actually not coincidental sometimes,
Okay.
especially if you jump straight into the type 1 type. There's an autoimmune phenomenon that can cause both seizures and diabetes. But if you have just type 2, it's probably not that thing.
Okay.
Okay.
And then what was my other question?
Hormones.
Yes. Are your seizures worse around your period, about 2 days before?
I think I started tracking them around on my period app because I thought so,
Mhm.
and now I got the Mirena put in, so hopefully I'll stop having periods at all until I
Yeah.
go into menopause. That's my
Yeah,
plan.
and so it's not so much the period itself, but what the period represents. And so what happens is, the hormones, especially the reproductive hormones in your body, specifically estrogen, fluctuate throughout the month. And it's when that rise happens, a very sharp, steep increase in estrogen,
Mhm.
and then the drop off. The drop off is what triggers the menstrual period, but that rise is what triggers the seizure increase.
So like a
We
couple
know-
days before your period?
A couple
or?
days. 1 to 2 days before your period is actually the worst time for people who have epilepsy and migraine,
Okay.
because estrogen makes both of those worse.
Okay. Good to know. And then Dr. Collier had me do a sleep apnea.
Mhm.
That was negative. She had me do eye ophthalmologist
Mhm.
test. That was fine. I
What was she
think.
looking for then?
I don't know. I don't know.
She said that she thought that people, now this was a long time ago that she first mentioned that,
Mhm.
that maybe oxygen deprivation with sleep apnea may have been a trigger or something.
Oh, I see. Yeah, that's possible. I mean, if you're already susceptible to seizures, then having sleep apnea will make your seizures worse.
Mm.
It's not often the trigger for the development of seizures,
Okay.
but can make seizures that are already there worse.
Yeah.
Okay.
Well, and I wasn't
sure about that.
I wasn't sure exactly which she said, just that it had an effect.
Yeah, that's right.
Okay.
Okay.
So
Yeah. So in terms of next steps,
yeah, can we? I've already reached my deductible and
okay, until when?
stuff until December.
Oh, sweet. So we'll
as-
take care of everything.
As many of these scans
Yeah,
that you
yeah.
want to plan this
Yeah.
year.
Yeah, so we'll do the PET scan for sure.
Okay. Do I do that in Grand Junction?
Um,
Or do
Yes, I mean,
Okay.
obviously it's such a drag to come down here. Do you come down here for any other reason?
well, I have daughters here, but
Okay,
I can.
okay, okay.
I can't drive really, right?
Mm,
I'm not supposed to drive.
Not,
so.
no, you're not supposed to. Yeah, it's-
Especially on the interstate, so
Yeah.
she'd have to take a bus over. Or,
I
Yeah.
wouldn't do that. Yeah, so if we had it done on the Grand Junction side, we'd need to find a group that could do the PET scan like we want it to, of just the head. Because usually people get PET scans for cancer, and it's a whole body thing.
Oh, yeah.
Yeah, we're looking just the head. We don't need the rest of the body. So we
if
need
you
to find-
think they can't read it as well as your
Then
experts.
I'd rather come over.
Yeah, they don't actually need to read it. They just need to collect it.
Oh, that's right, because you can send it.
Yeah.
Tech-
Well, yeah,
technology.
and you can bring the disc with you. If it's in one of the systems that we have an agreement with, we can actually look at it directly.
Mhm.
Well, we'll figure it out.
Okay.
Okay. Yeah, we'll figure that out. So the WADA would need to be here. Okay, so that would be another visit. But if you have a place to stay, that's great. Because I
Okay.
wouldn't want you sort of jumping in the car for a 4-hour drive, that day.
Yeah.
Okay, you'd want to rest because it's
Would
a
she
large,
be
it's a
able
large
to-
vena puncture.
Yeah.
Have a granddaughter take her back to, or our other daughter, take her back to Longmont like that?
Yeah, that's fine.
Yeah.
That same day?
It doesn't matter, I mean, would she spend the night here?
No, so you would sort of be in a recovery area for a few hours and then go home. And so theoretically, once you leave here, you should be okay. But hopping into a car for a 2-hour drive is still a little bit.
Could she
dicey.
go from here to Longmont? Or would you rather they
A
stayed in a
hotel?
hotel?
It would be better. Okay, so when you say you're over on this side, you don't have family in Denver.
I know. Sorry.
Okay.
Boulder and Fort Collins.
Oh, Boulder's okay.
Boulder's okay.
I would say 30-minute drive is not bad.
I have Longmont, Boulder, and Fort Collins.
Yeah. Are you able to stay with your Boulder family?
Yeah.
Okay. Yeah, I think the shorter drive would be safer.
Okay.
And when we sort of organize that, I'll make sure that we sort of keep you in recovery longer, as long as we can.
Okay.
Okay.
That all sounds good.
Yeah.
So so I'll just plan on seeing you or make an appointment. How do I?
Yeah, so I'm going to talk with Gaitha. She's our program coordinator for this group. We'll organize the PET scan. We'll discuss scheduling for the WADA test. I'll speak with my private practice office about scheduling you virtually. we'll have this conversation again. You had a few seizures, so even though you look awake and alert, you might not remember much of it.
Yeah, probably not.
Yeah, so I'll probably have this conversation again in about 2 weeks.
Okay,
Okay? And
That's
then,
great.
and then we'll kind of go from there.
okay.
Okay.
And
Do you
then
live on the other side too?
Yes, I do.
Okay.
I'm going back to Ann Arbor though for 5 weeks.
Oh,
but
fun.
We'll,
Okay.
that's my hometown.
Okay. Are you going to Ann Arbor also?
I'm going to Michigan for a week.
Okay.
Yeah.
Cool. Yeah, if you want to do a virtual visit then
Yeah,
together, it'd be nice to have some
Yeah.
family who knows what
That'd
we're
be
talking
good.
about.
We could do it from Fred's house.
Yeah.
Yeah. Yeah. Okay.
okay, and then, you'll talk to Dr. Collier in the meantime?
Mm-hmm. Yep.
Okay.
I'll
Should
let
we
you know.
give you the week that she'll be there, that we'll be together?
In Michigan?
Yeah, whatever's more convenient. So I'll have our office reach out to you to schedule it, and
Yeah.
then, yeah,
Okay.
I don't
Yeah.
know.
How soon did you wanna see me?
Usually about 2 to 3 weeks after the
That'll be
EMU.
just about Michigan time.
We're gonna,
anyways.
I'll be there for 5 weeks, but my kids will all be there from 23rd to the 30th.
Yeah, so if you
that's-
can, just make it right through that week, that'd be perfect.
That'd be
Mhm.
great.
Yeah.
And then go
Okay.
swimming in Lake Michigan.
Yep.
There you go.
Okay.
With a big floaty.
Yeah.
Yeah.
Yes. Lifeguards.
Yes.
Okay,
Okay.
well, thank you
Yeah, you're
for all
welcome.
your information.
Okay.
It was
I'm
very
glad you-
helpful.
I'm glad you recorded it.
Yeah,
Because it's a lot of info.
it is.
It is a
And
lot
I never
of
remember
information.
anything.
Very good. Yeah, if you can think of anything